And joining us now on the debate, David Kaplan. He's Vice Chair of Global Public Affairs and a former Ontario Minister of Health. Steve Lurie, Executive Director of the Canadian Mental Health Association's Toronto branch. Kimberly White, Associate Professor of Law and Society at York University. Jennifer Chambers, Coordinator of the Empowerment Council. And we welcome back Dr. David Goldbloom of the Mental Health Commission of Canada. Good to have everybody on the program today. Thanks for joining the good doctor for our discussion. I think just so we're all on the same page, that got a laugh already, eh?
Yeah.
Because they don't all think you're a good doctor.
That's right, I'm usually just the doctor.
This will emerge, this will emerge. Let's share with you and our viewers some of the facts that came out of the Mental Health Commission report today. We'll put those up on the screen and then we'll go from there. Here's mental health by the numbers. In any given year, 1 in 5 people in Canada experiences a mental illness, costing the Canadian economy, as Dr. Goldbloom just told us, in excess of $50 billion. Mental health problems and illnesses account for approximately 30% of short and long-term disability claims. Mental health problems and illnesses also account for more than $6 billion in lost productivity costs due to absenteeism and presenteeism. Haven't heard that word before. Rates of mental illness for adults between the ages of 70 and 89, including but not limited to dementia, are projected to be higher than for any other age group by the year 2041. Up to 70% of mental health problems and illnesses begin in childhood or adolescence. As many as 3 in 4 children and youth with mental health problems and illnesses do not seek access to services and treatments. And finally, Canada spends considerably less on mental health than several comparable countries. We talked about this too. Canada spends about 7 cents out of every public health care dollar, 7% on mental health. This is far below the 10 to 11% of public health spending devoted to mental health services in countries such as New Zealand and the UK. That from this report, which came out today. Okay, let's go around on this. David Kaplan, a lot of celebrating at the press conference today. You saw Valerie Pringle off the top of the program, whoop it up. Sure. Is there much to celebrate?
There's a lot to like about the report. I was chatting earlier, great parallel between some of the work that we did in Ontario and with the National Commission report. I especially like a couple of different things that are in there. They note that the transition from children's mental health services to adults is a particularly rocky one, and one that we really need to pay some particular attention to, because a lot of children, adolescents get lost moving from one system to the other. Different criteria, different treatment, different supports that are available, and that's an area that I think we need a lot of focus. Another area that they point out is training. And not just for health professionals, but really across the board, whether that's teachers or people who are working in law enforcement.
Cops,
and other
firefighters.
Absolutely, other areas. My wife is a nurse, and she tells me that she could use a great deal more training when it comes to dealing with mental health issues that arise. She specializes in diabetes, and there is a mental health component there.
Okay, and 2 good points. Hold that thought.
One more.
You want one more?
Well, and
everybody's going to want then 3, David.
Okay.
All right.
But I think the focus on seniors is also really good. I mean, we've got a demographic tsunami coming our way, and we've got to prepare for what is really on our doorstep. So just understanding that we have a large graying population that is experiencing and going to experience significant mental health issues is, I think, very timely and is a good recommendation.
You said graying population, and look who's sitting beside you.
Well,
I believe this is premature.
I'm no spring chicken myself.
Okay, much to celebrate here, Jennifer?
I thought it was a very good report. I particularly like the acknowledgement it gave to the importance of rights and the empowerment of people who have been on the receiving end of services. And one of the ways it did that came out in the original Senate report, went missing from the subsequent report and is now back, was the idea that, like people with physical disabilities, people in the mental health system could take some control of their own resources and decide how they would best be allocated. There is evidence suggesting that does create more effective services than any other approach.
So you like that?
I do.
Kimberly.
I think on the surface there's a lot to like in this report. I'm very interested in the work of the Commission in a broader historical context, and I'm sort of tracing the work and the development of the production of mental health knowledge and how that's happened in the context of the Commission. And so there have been, over time, some really good changes that have now been reproduced in this document. In particular, I'm happy to see the dropping of the word disease, which early on was very, very prominent in the work coming out of the Commission, and that seems to have been tempered a little bit.
Explain that a bit more. What do you mean?
Well, there was a very clear statement early on that mental illness is a disease like any other disease, and that rubs a lot of people the wrong way.
You don't think it is?
It's not. I mean, it's not what I think it is. I think historically that word is very loaded and comes with it a number of connotations, and we respond to diseases in very particular ways. And
so a better way to describe it would be what?
Well, I mean, I think illness is almost equally as problematic, but it's gentler than disease, which again is just it provokes really problematic histories in this country, and it individualizes in a way. So I'm happy to start off being a happy point. I'm happy to see the
There's a however coming.
There's no. Just and I'm also happy to see, because early on I wasn't entirely convinced that this was going to be able to happen, but there really does seem to be a genuine effort to be more inclusive and to be more expansive at the same time. So while I would like to see more kinds of inclusivity, for sure, I do think that one of the quite new things about this work is sort of bringing people in that have not been part of this conversation historically, and also to expand it to areas that have been excluded from all of these initiatives in the past.
Well, it was very inclusive to Steve Lurie. You were part of this commission, right? You had a piece of this action. Do you really believe, if we look down the road 15 years or so, that this report will have actually moved the yardsticks in this country? And if so, how?
I think it will, because it's a very practical report. For people who haven't memorized it yet, you can see that there are examples from Canada as well as international that provinces and territories and regional health authorities can pick up and run with. They can start by with a little bit of money or a little bit of changing their process. But to give you an example, David mentioned that he was very pleased with the focus on seniors. Well, the Commission just published a guide for the care of seniors. It's there. There's no reason why every community organization and every general hospital in the country can't be having a conversation tomorrow about how do we implement that.
You can have a conversation about it, but money, resources, personnel?
Well, absolutely.
Is that going to follow?
Well, training is possible now. I mean, there's a coalition that has been doing a lot of this work to begin with. On peer support, the Commission has begun to mobilize resources for peer support. We actually have some targets in the report in relation to supportive housing. So I think it actually moves the yardstick because it was built from the ground up. They looked quite carefully at what was going on. They commissioned a number of reports through the advisory committees. For example, my advisory committee had Quan McKenzie lead a piece of work into what are the mental health needs of immigrants, refugees, ethno-racial and ethno-cultural and racialized communities. And there's a 16-point plan there. Some of these things take money, but some of them take planning and policy development. So I think the report actually gives the Canadian public and governments and service providers some places to start.
Let me follow up on this vocabulary notion that Kimberly brought up a moment ago. Your report, David Goldblum, doesn't talk about a cure.
Right.
It talks about a notion of recovery.
Right.
Explain the significance of the different words.
Absolutely, and it is an important difference. The word cure is a very seductive word. Everybody responds positively to the idea of cure. And the reality of modern healthcare is, in fact, mostly not about cure. And I'm not talking here about mental illness. I'm talking about health in general. Most of our work in health is not related to cure. Most of our work in health is related to minimizing the intrusion of problems and illnesses on people's quality of life and functioning, maximizing their sense of fulfillment, productivity, and playing to their strengths. That's what recovery means. That's what it means certainly in the context of mental health. And it does not mean curing schizophrenia, curing depression. Does it mean, hopefully, getting symptoms that are profound and destructive and bothersome at bay? I sure hope so, but it's way more than that.
Jennifer,
in terms
does that
of
work
a
for you?
broad view of life.
Does that approach work for you?
That definition of recovery? Yes, I think that there also is evidence that people do recover to a considerable extent in the sense of not being impeded at all in the way that they live their life from things that people had previously been told were sort of illnesses that they'd have for the rest of their lives and they'd have to take medication for the rest of their lives. So I don't think that's really filtered through to the public that that's the case, and it's good that that's used as a value in the system.
David?
We're certainly thinking about our healthcare system, not just mental health, but about chronic diseases that people are living with, diabetes or cancer or cardiac, and that there's nothing that should prevent them. They shouldn't, first of all, be defined by their disease. There's nothing to prevent them from participating fully in society with all of the baggage and all of the challenges that they have. I break it down into a very simple notion that anybody wants to have a home and a job and a friend. And all too often what's happened in populations that have had mental health issues is a sense of isolation. They've been put over there. They've been segregated from the rest of us healthy people, and that's created even greater and compounded problems. So the notion of recovery is in fact a very important one for the integration and introduction and the support that people would have as a full member participating in society.
Steve, my hunch is in this economy, the job and the home are going to be very tough to come by, even with the good work done on this report. Fair to say?
Well, I think it's going to be a challenge, but I think we have lots of programs, and the Commission is putting out a report on the aspiring workforce. There are already examples in the country of organizations that leverage other sources of funding to help people get work. For example, my branch of the CMHA has a program where we leverage ODSP funding here in this province.
Ontario Disability Support.
Yes, and we help create jobs for 300 people every day. And we have about a 60 to 70% job retention rate. So some of this will be about, as the report says, finding money outside the healthcare system to make the investments. The housing piece is actually a question of figuring out strategically, what do you do first? A rent supplement costs $6,000 a year. That's a lot cheaper than $175,000 to keep somebody in hospital. So governments need to choose not so much what to invest, but also, if they make certain investments, they're going to see expenditures decline in other areas.
Rent supplement doesn't help anybody who's mentally ill and on the streets living as a homeless person.
It can, though.
It can.
It can and does.
Look, I think, let's go back to the At Home Chez Soi project as an example of recruiting 2,000 Canadians in 5 different cities who found themselves homeless and suffering from a mental illness, and randomizing them in a research study design to treatment as usual versus a housing first intervention. And the final results will start to come out in April of 2013 when this study comes to its conclusion. But I think what we're going to see is a significant difference in a whole bunch of areas around employment, around incarceration, because it's extraordinarily expensive right now. Even though it seems like, well, that person is paying nothing to sleep on a grate, well, they're paying hugely in terms of human dignity. But our society is paying hugely in terms of shelters, emergency rooms, jails, that really don't help that person on a path to recovery.
So let me ask Kimberly then, there was a cry out there for people with, and I believe the expression is lived experience with mental health, to be an increasingly larger part of the solution going forward. 2 things. Does this report acknowledge this adequately in your view? And if not, how much more do you think we have to do on that?
I think it represents a certain segment of the population of individuals with lived experience. I think that there's also a large segment that is not represented here.
Who's not represented?
Well, I mean, again, and I completely understand why that may have happened, but the more sort of critical and politically identified groups that would align themselves with Mad Pride movements, with psychiatric survivor movements, which are intended to, very clearly position their political identity as survivors of the psychiatric system and not of a psychiatric disorder. I mean, I think there are lots of other voices out there that aren't being heard and perhaps aren't even accessible. So in terms of, who is coming out of the shadows, I would say it's a little bit of cherry picking in terms of who's being represented and what stories are being put out there. I mean, the mandate is set. The social marketing is done. There's an image that needs to be projected, and I would argue that it is those stories that are in line with with that objective that are going to be promoted the most.
Cherry picking, Steve?
Well, I don't think so. There was a lot of work that went into the Commission strategy, but for example, 2 of the reports that my committee did, one on peer support, we consulted with close to 1,000 people who were involved in peer support across the country, people who were running groups like Chanel in Newfoundland and Labrador, people who are running wellness recovery action programs, a small group that's been meeting for 15 years in a village in Quebec. So there was a real attempt in making the case for peer support to really talk to people who had experience with it. We found that it's hanging on by its fingernails across the country and it needs to be better resourced and better supported. But that's just one example. In Turning the Key, where we identified there's 520,000 people who are vulnerably housed or homeless, but we had a group of people who have lived experience comment on what they needed in relation to housing. And that's one of the reasons why we came up with the notion that, you know, you have to provide food security, adequate income, peer support, decent housing, and access to services. So I would say, tucked in the strategy, and as the Commission works with provinces, territories, and providers, service users, and families to begin to roll out these initiatives, there's a lot of work behind. I mean, that's a 150-page book, but there's thousands of pages of testimony and discussion with people.
No, I hear you, but then it goes to the issue of whether the people who don't feel included in this are in fact included in this. I want to bring you in at this point, David, because when you were health minister, you tried to mount, I guess, a mental health summit where you tried to get a lot of the different players to come to a single location and, you know, hash out some ideas. Yes. Does Kimberly have a point that there are those who want to be included in these things, but sometimes aren't?
Well, and it's a valid point. Sometimes we don't know how to engage and to bring them in. Sometimes, you know, it's just practically challenging. So trust is a big issue. It's oftentimes difficult for people who have been isolated or minimized to feel that they can be comfortable.
How about those who are politically a pain in the neck?
Those too. Absolutely. It's quite a wide group, but I will say that my experience, I said to my officials, I want to have 1,000 people, and they thought I was completely bonkers. That this had never happened before, that this could never happen. We had over 1,100 people in the middle of the summer come, and it wasn't just people from healthcare. It was from education, social services, from legal. We had and invited people with lived experiences to come and want to participate. In fact, that was the focus of the panels. We wanted to have people tell their stories to make it very real and to bring it down to a level of, okay, so this is what it is. This is how it affects people. Now, what could we collectively do in order to marshal ourselves to bring our resources, to bring our desire for change, and to make that real for the people who have told us their stories, anecdotal as they are.
Let me do a couple of items. Yeah, sure. You want to pick up, and then I'll do a little business with the folks at home. Go ahead.
I was going to provide a little sort of real-life context to the empowerment of people who've been on the receiving end of services. One of the ways that people who've been in institutions in Ontario have been empowered is through the council system. We represent the clients at the Centre for Addiction Mental Health. Other hospitals in Ontario have had councils whose power has actually been progressively eroded over the last 10 years or so. People who previously had control over their own sort of agenda and policy are now finding that their staff are taken away from them, and hospital staff.
This you represent the council,
yes.
the Empowerment Council.
The Empowerment
you don't work for CAMH.
The Empowerment Council is funded by CAMH, and the CAMH has been very supportive of us as an independent organization. And we're independent so that we can speak clearly on behalf of clients without the impediment of worrying that every second the wrath is going to fall on us for speaking clearly. But we do recognize also that sometimes we feel like we risk our funding by speaking clearly, purely from the client perspective. And we've certainly seen other organizations that seem to have been punished for this. They've had the control of their own organization taken from them. And I think it's not just, money isn't going to be the only thing holding back the goals of this report. Advocacy in Ontario is being eroded. The Patient Advocate Office now has one of its advocates reporting to directly to the hospital, sort of like a union reporting to management. And that, combined with the councils losing some of their staff, makes me very worried about how much the province right now really wants to hear the voice of the people themselves. And I think it's great that the report is supporting the importance of that voice, but in this context, it's worrisome.
Okay, you'll notice throughout the course of the evening we've been bringing up on the screen here either elements from our live chat or some people have tweeted in. There are many ways for you to get involved with our broadcast. tvo.org/mental health matters is the website where we are live streaming this. We've got people standing by to take your phone calls and your tweets if you want. Also on Twitter, hashtag the agenda, hashtag mental health. Chime in, we'll get your comments up on the screen as much as we can. Now, to that end, we did a program, you were there. We were taping a program at Hart House on the weekend at University of Toronto. And Thomas Unger, who's a chief of psychiatry at North York General Hospital, was there. And on this issue, we started to talk about the issue of whether or not big public campaigns can actually help mobilize and change public opinion on a lot of the issues that we're talking about during the course of this week. Stigma, etc. And I want to play just a snippet of what he had to say and then come back and talk about that angle in this story, okay? Roll tape, please.
You know, they're doing research on anti-stigma interventions, and public awareness campaigns aren't at the top of the list. The top two things of the 5 interventions are contact with persons with lived experience, patients, consumers, survivors, clients, whatever word we use, and structural intervention and structural change. And I'm actually really big on that one because for stigma to occur, there's got to be power differences. So if you create structures, policies, rules where the power is equal, stigma is going to reduce dramatically. I mean, in numerous emergency rooms where I may have to work in my career in the middle of the night, the mental health space where we assess patients is, sad to say, often the smallest, worst renovated, converted broom closet space compared to the all beautiful high-tech other parts of the house. So if you intervene structurally, that's going to probably do a lot more to reduce stigma. Public awareness is great, but if there's no bite to it, it's only going to go so far.
David, I don't think David Goldblum first. I don't think he meant to sort of poo-poo the $50 million that Bell Canada's got out there as an anti-stigma campaign, a public education campaign. Right. But contact and structure, he seemed to think were far more important. Is he right about that?
He's right in the sense that contact has actually been demonstrated by the evidence to be the most effective of the 3 forms that we traditionally think of anti-stigma intervention, namely education, protest, and the third one being contact. And I think, you know, to boil it down, there's nothing like having a very human encounter with somebody who's experienced a mental illness to defang, demystify, detoxify what is, for many people, an anticipated threat to their own sense of humanity, individuality. And so encountering the humanity and individuality of another person who's been through it, I think goes a long way to changing attitudes. But, you know, attitude change is only a tiny part of this. It's behavior change, and that takes us into the structure issue. Because if you don't change the attitudes and behaviors of people who run general hospitals, for instance, around how they are going to accord resources and space, and everybody judges their importance in the hierarchy, certainly in a hospital, by space. They count the ceiling tiles and see how many they got in relation to their neighbor. It is absolutely true that in general hospitals, all too often mental health services are shunted off to the margins, the last places to get the kind of attention they need, and so that for people coming seeking help and seeing how the institutional structure reflects their needs is a disheartening experience.
So David, if it's about contact, I'm going to ask you a bit of a personal question here, because Senator Michael Kirby was on this program telling us that one of the reasons he was so adamantly involved in this issue is because he had a close family member who suffered from mental illness. You were Minister of Health, and you made this a big priority when you were the Minister of Health. Sure. Do you have a similar story?
Well, first of all, I don't know anyone who doesn't. People who come to this, they have either themselves or family members, friends. I can tell you that, you know, within my family, my great-grandfather was, he's written up in the psychiatric books. He was in a catatonic state for over 30 years. My grandfather was one of the first lithium patients in the city for, you know, severe depression. So yes, it has come very close and touched me in ways that I don't even probably recognize myself. I wanted to comment, though, on Dr. Unger's second point, was the power imbalance, because that's very true, not simply in mental health. That's true in healthcare in general. I don't know a lot of patients or a lot of clients, if you will, who are prepared to challenge or feel that they have the power to healthcare providers. There is a tremendous imbalance in the way that people approach healthcare in general. And I think that is, if we could change one thing, we talked in the work we did in Ontario about the notion that you see now is something called patient-centered care, and I really don't like that. What that says is we have the patient at the center, and we're going to tell that person what they need, how they're going to interact, where they're going to go. I very much like the idea of patient-driven or client-driven care, where you're much more of a consumer. You take a much more active role in asking the right questions and directing the kind of care that you feel that you need at that particular point, what you're ready to do. And I congratulate the Commission because they kind of have worked toward adopting this type of a notion in what they're calling for as well.
Kimberly, oh, sorry, Steve, you go ahead, then I'm going to read something
Just
to Kimberly.
to pick up on that, one of the things, again, in the report is that the report talks about the Ontario Common Need of Assessment project, which is precisely that. There's a consumer questionnaire where service users get to say what their needs are. And then professionals do a similar assessment, and then the goal is for people to talk about, well, what would make a difference for you? And you actually are going to be able to get, within a couple of years, a set of what needs are being met, what needs are being unmet, whether people want the help, what type of help they want. So actually, there's an example in the strategy of moving towards a person-driven system, because people have to define what it is they want, what it is they need, what kind of help they're willing to accept. And I think that's a very practical thing that we can build on nationally. There's been a wonderful project here in this province to move it into community mental health. It's also being used in consumer survivor initiatives as well. So we've actually got some promising practice here on that front that is easily translatable into other jurisdictions.
One of the complicating factors involved in all of this, I gather, is that there are two very distinctive sides on this coin in how to approach things. And Kimberly, I want to read this from the National Post from last fall and then come back with a question to you. The Mental Health Commission of Canada is trying to strike a balance between the two major ideologies of mental health: empowerment, based in social science, in which recovery is seen as a personal growth experience, and psychiatry, based in neuroscience, in which recovery sometimes must be imposed against a delusional will. At its most extreme, this clash of ideologies turns on the question of whether the fundamental problem of mental illness lies in the brain itself or in the stigma imposed by society. In your view, how well have they done figuring out the common space in those two different ideologies?
I think they've actually done an admirable job of trying to represent both of those views. It is incredibly difficult for us as a society to accept that there may be two answers to the same problem, that there may be no answer to the problem. We're not very good on ambiguity. We want certainty. We want to know what the cause of things is. And this is just one of those issues where, getting bogged down in questions of cause it just sort of stops things, right? Because whatever you determine the cause to be is going to determine then what you imagine the response ought to be. And it's been stated very clearly that there are many possible causes and combinations of factors, and that may manifest differently in individuals. And so, I think when I read that article when it came out, and I actually, it was the first time I felt like real human emotion for the work of the Commission. It's like, wow, I mean, that's a really tough thing for them to do. And it was clear early on in the work of the Commission that was something that they were trying to deal with.
You've surprised me here tonight, I have to tell you, because you've been pretty critical of the Commission, the process, the way by which they've come to everything, and yet tonight on this program,
I'm not being mean enough.
Well, I'm saying you've had a lot of complimentary things to say.
Well, again, it's on appearance. These are really difficult things to try and strike a balance, and so I think they've done that. I think they've gestured towards both of these, and I think when that came out, there were also some really, quite offensive references to, you know, why would you consult sex survivors? Way too much attention given to what they have to say. I don't need to explain why that's offensive. You know, that recovery is mentioned this number of times, and, you know, bipolar and schizophrenia are barely mentioned at all. And so I can see, you know, from the leaked version to the official version, the trying to kind of, you know, work that in. And there's always a cost when you try and balance. Something gets lost. And so part of me would like to see a strong position taken on, you know, recovery, not a watered down version of recovery, but the, you know, the sort of genuine meaning of recovery as self-direction. But I do get that you can't cut off the psychiatrist.
So let me ask David Goldblum, how have you in this report tried to kind of rationalize those two very different ideologies?
Well, picking up on this point exactly. I mean, we talk about recovery, we talk about rights, but we also recognize that in Canada, as in every democracy, there exists mental health legislation which empowers physicians in the state to temporarily abrogate, to withhold some pretty fundamental civil freedoms that we place high value on. Right? Freedom of movement, freedom of choice. Those are heavy responsibilities on any physician who exercises them. And so that in order to be consistent with the Convention on the Rights of People with Disabilities, we need to be sure that there are adequate safeguards in place, that these are used as last resort mechanisms when people cannot be engaged voluntarily, and when on the balance of probabilities, their acute mental health needs at that moment necessitate that level of intervention. The report does not do away, as some would want us to do, with mental health acts that deprive people of those fundamental civil freedoms, but it places a lot of weight on doing things differently. And you know, there again, to Steve's point about practical examples, in our own hospital, at Hamilton, at St. Joseph's Hospital, initiatives to reduce significantly the use of things that are highly coercive, like seclusion, like restraint, have been affected by engaging very differently with people with mental illness, thinking differently about how to approach these problems. It can be done.
So let me go over here to Jennifer, because I gather your group has to represent people who describe themselves as psychiatric survivors.
Yeah, however people self-identify, we'll represent them.
Do you think this strategy does anything to bolster their concerns or their rights?
It does. It does mention the importance of having clients involved in policymaking and in directing their own care, and I thought that was great. As far as people's rights go, I thought it was good that the Commission was supportive of legislation coming or rights being in line with the UN Convention on Persons with Disabilities. I was curious, they didn't mention the Charter, however, which is what we most often use when we are appealing how people are treated in Canada. We appeal under the People's Charter rights, and we've had a number of cases that have gone up to the Supreme Court that we've won on that basis. So I was surprised that wasn't used. Perhaps it was because there was a reluctance to acknowledge that some aspects of the legislation in Canada do violate the Charter, which I think they do. Some provinces worse than others. But the need to occasionally use what Thomas Unger was talking about, the need to resort to structure, is why we sometimes have to go to the law, because we need that structure laid out in order to be able to get people's rights on the ground respected.
Let me go to David Kapp. We've got just a few minutes to go here, and we've got to talk money.
Because I don't have any.
I know you don't anymore. But here's the thing I want to understand. If we're going to move the percentage of the money we spend on healthcare in this province from 7% on mental health to say 10 or 11%, as other jurisdictions do, and we're not going to spend more because we're not going to spend more, how impossible is it to reallocate a $47 billion healthcare budget so that you can put more into what you want to and less into what you don't want to?
Well, it is a question of will. However, we had this conversation just prior to the show. So what do you take the money from? Do you take it from long-term care, from home and community care, from cancer, from cardiac care? Do you take it from physicians? Do you take it from nurses? Where
Apparently you're taking $300 million from doctors. That's the last thing I heard, but anyway.
I don't know any group within the healthcare system, any advocate who would say that there's enough money for what they're currently doing. And I know as Minister of Health that I faced the kind of pressure that there was about, I don't know, 3 or 4 times more in demand for various services, and all very well rationalized. So this is a real challenge. But there are ways to be able to do this. For example, the report talks about the third way, the role of philanthropists, those outside of government. So I love the notion of challenge funds. Government puts up something, let's say the federal government says, we put up 1/3. The province matches with a third matched by the private sector. That's one way of getting some new dollars, or refocusing and shifting dollars. I like the idea of when you're coming out with a chronic disease strategy, let's say you're doing diabetes, build in a component of that to have a mental health perspective, or some funding associated with meeting the mental health needs of people who are managing their chronic disease, whether that's cancer or whatever that happens to be. So there are ways that you can shift resources. I think there are ways that, and governments are looking at ways that they can shift from current-based institutional care. I mean, David talked about, or somebody mentioned, what it costs to incarcerate people, and much better spent if we supported rent supplements or affordable housing, so there are things that you can look to shift from institution-based care into more community-based, far less expensive, and also far more effective when it comes to meeting the needs of that population.
We're coercive to more empowering models, also
Absolutely.
more effective and more cost effective.
Yeah.
We're literally down to our last 30 seconds here. I want to give it to the chair of the Mental Health Commission and tell us where you think 10 years from now this report will take our country.
I think and I hope it will improve the lives of Canadians facing mental health problems and mental illnesses and their families, and that it will overall contribute to better mental health for all Canadians.
Good place to leave it. David Goldbloom, Chair of the Mental Health Commission of Canada, also with CAMH as well. David Kaplan, Global Public Affairs, the former Ontario Minister of Health. Steve Lurie, Canadian Mental Health Association, the Toronto branch. Kimberly White from York University. Jennifer Chambers, Coordinator of the Empowerment Council. It's good of all of you to come on our program tonight. This is only night 2 of 5 that we're doing on Mental Health Matters Week here at TVO.
Support Ontario's public television. Donate at tvo.org.